Tamil Nadu. Sir, I request you to chair the next session.
So, good morning to one and all. So, at the outset, my sincere thanks to Dr. Jodi sir for keeping me a part of this JPEF. So, this session is need of early screening, diagnosis and management of chronic kidney disease. How to early diagnosis and what are the role of POCTs at the clinic level. So, we have an eminent speaker. He doesn't need any introduction, and he has just one word about this word has been seen is contribution of an immense effort of diabetes care has been taken to greatest heights by one and only Dr.Banshi Saboo sir.
Thank you Balaji for kind words of introduction. Once again, thank you Jyoti Dev, JPEF, Organizing and Scientific Committee for this wonderful opportunity. What I am going to talk as CKD is very silent. So detect in time and protect in time. That is what we have to do. To start with, we know that CKD is increasing and leading to complication and increasing mortality. New medications are now available. We are using for our patient with CKD as SGLT2 inhibitor, MRA, which may prevent and slow down the progression, therefore reduce the morbidity and mortality in CKD and its complication. We can only treat what we know, and this is very, very important sentence. Unless you think of it, you will not treat it. That's very important. And urine albumin creatinine ratio, which is a very early marker of CV risk as well as kidney damage, that generally occurs before even eGFR start declining. So now we do creatinine and we also do the calculated eGFR. But before even eGFR starts declining and then we start calling the patient of CKD, the urine albumin creatinine ratio is very, very early marker which we can have. A point of care testing for this urine albumin creatinine ratio before even serum creatinine is now recommended by international guidelines including KDIGO. KDIGO, International Society of Nephrology, even the Primary Care Diabetes Bureau, and some of the national guidelines like RSSDI in Diabetes India, they recommend that the screening of patients at risk who are having hypertension, diabetes, cardiovascular disease, and family history of CKD. So I mean, even a person who may not be having diabetes but other problems, they all should be screened for urine albumin creatinine ratio. It is found that diabetes and CKD is a condition not in top 10, which is leading to increasing risk of death. But probably by 2040, both these conditions will be in the top 10 conditions in the world, which are the reason for them to die. Definitely cardiovascular disease and stroke, lower respiratory infection and COPD will be always there, but the cancers and other things will be there. But in top 10 conditions, the CKD and diabetes will be there for that. The high prevalence of CKD in APEC region, and this is one that in China and India, the number of persons with CKD, I mean all of us, we know that diabetes is a condition with 101 million people in India, but you will be surprised that we have CKD problem. If I just get the urine albumin creatinine ratio high, if I put all of them in the condition of CKD because of chronic kidney problem, they are having chronic kidney disease, number is 108 million. So to our surprise, it is more than that what we have diabetes in our country. How you define CKD? Chronic kidney disease is defined as abnormalities in a kidney structure or a function which is present more than 3 months and which have implication for health. So the CKD definition is abnormalities of kidney structure and function for more than 3 months which implicates for the health. And criteria for this, definitely decreased eGFR of more than that, but there are presence of marker, and one of the very important marker, as I told you, is urine albumin creatinine ratio. The prevalence of underlying cause of CKD in India, if I just say that all of the condition, out of them 25% to 30% of them is because of diabetes. So diabetes kidney disease is one of the leading reasons for them to develop CKD. But yes, there are other issues also, like very common is chronic interstitial nephritis. There may be still unknown conditions are there, and chronic glomerulonephritis. Then hypertensive nephrosclerosis. These are the 2-3 major reasons for them to develop chronic kidney disease. The cardiovascular disease, diabetes and a CKD. This is a very vicious cycle. A person who is developing CVD, developing CKD and developing diabetes. So the cardio, renal and this metabolic problem is very complex, very interlinked, and also early kidney disease is usually asymptomatic. So patient with the even slightly creatinine is increasing, slightly decreasing eGFR, slightly increase in urine albumin creatinine ratio or albuminuria, they are completely asymptomatic, and for that a clinician should check it. And that's what the statement which we have done in the first slide only, that if you know, if you think of it, if you have a high suspicion, then only you are going to detect it, and once you are going to detect it, you are going to treat that condition also. So this cardiovascular disease, diabetes and chronic kidney disease, as I told you, they are very interlinked. The persons with diabetes are higher risk of developing CKD. The persons with CKD have higher risk of developing cardiovascular disease, and the same, this keep on, the vicious cycle is very high. The kidney disease, albuminuria is an early marker of, as I told you, not only for the kidney disease but also a marker of CV risk. Generally it occurs before eGFR starts declining, and already a person with a urine albumin creatinine ratio level in the normal range is around 10 micrograms. Still we consider more than 30 micrograms if urine albumin creatinine ratio is positive, but more than 10 is actually a very earliest marker. This is what that, and it increases in all-cause mortality in general population. So suppose in a mass we start doing urine albumin creatinine ratio, those who have more than 10 micrograms even, it increases overall in general population, all-cause mortality is higher in those population who have more than 10 micrograms too. The kidney function test, which routinely we do with the eGFR calculation, since last 25 years, 30 years, we are talking every time that just don't depend on the creatinine. Different labs may have different value. Calculating eGFR is the most important thing, and now we are doing everything with eGFR. But the kidney damage, the first, as I told you, urine albumin creatinine ratio, and this is one paper that measurement of renal function in patients with chronic kidney disease is the most appropriate for a first-line test for a detection of proteinuria in CKD, one of the most sensitive, qualitative and a standardized measurement of loss of protein. The Kidney Disease KDQI Quality Incentive Initiative by National Kidney Foundation for screening for CKD and monitoring of CKD through urine albumin creatinine ratio, and this point of care testing is now acceptable across the world. Urine albumin creatinine ratio is predicting CKD risk, which is very high sensitive, and it is very crucial too. There is a limited knowledge. As I tell you, the primary care physicians are not doing it, and that's the reason the primary care diabetes Europe and endorsed that early detection of CKD is the only way. So the nephrologist, if you invite nephrologist to give a talk in either diabetes meeting or in a primary care meeting or a physician meeting, why patients are reaching them with chronic kidney failure? Because someone has not detected early in the course of disease. I mean, not at the level of urine albumin creatinine ratio is decreasing, increasing, or they are not referring at the right point of time, or now there are medication that you can completely change the progression of chronic kidney failure too. So there is an inadequate healthcare professional knowledge of CKD. A current estimates that primary care provider recognition of a kidney disease remain alarmingly low, and indicating a strong need for an educational effort on CKD among providers. Improved CKD awareness will drive routine point of care testing and improve recognition of early stage of CKD for implementation of evidence-based medication design. This is KDIGO and ADA, a diabetes management in CKD. So we have the GFR with G1, G2, G3, A, G3, B, G4 and G5. So 6th grade of GFR, which can be on the left side, while albuminuria category is A1, A2 and A3. So you can see here the people with albuminuria or even A2 and A3, even their eGFR is absolutely normal. G1, it is more than 90. But still, they are moderately increased in the risk of kidney failure, and they are severely increased in the risk of kidney failure. So the albuminuria, even their eGFR is absolutely normal, or even they're more than 92. This is a poster format where primary care diabetes Europe along with KDIGO had put it, and for the primary care physicians, for the general practitioner in India we have 100,000 primary care physicians who are taking care of it. So the early identification and how they should intervene at a primary level, in a simple poster they try to show that everything what you should do what are the point of care testing, how they can progress, and what intervention they can do. Definitely intensive blood pressure monitoring, control of the blood pressure, cholesterol, and all those things should be done. But there are hurdles in screening in real world. So you know what I talk till that? There are problems. There is a problem of people are not knowing, the awareness is poor, and the CKD can be detected as early as just by doing a point of care testing. But there are hurdles, even if it is so easy. One is that compliance is very poor. Even if you write a patient for urine albumin creatinine ratio and going to a clinic or a lab, they lost. They may not come back to you for the report. That's number one. Then definitely the cultural issue patient may not get. And urine albumin creatinine ratio, one very important thing which I will tell, that people go for the routine health checkup. But most of these big labs who are taking care of your all labs report, they do only blood reports. They don't do the urine report. So we are completely eliminating, and the urine testing is not done at all. So that is what a point of care testing at the level of physician will definitely help and improve this compliance too. The POCT flow becomes very easy because as soon as patient comes to your chamber, you have to get either with A1C, along with that you get the urine albumin creatinine ratio, and the same machine Affinion 2, which is doing urine albumin creatinine ratio with A1C2. Results is in front of you within few minutes. You can interpret and you can discuss and you can plan the treatment simultaneously. So in the one sitting, at the time of the consultation itself with the point of care testing, this benefit is always there. KDIGO also recommend, it is in 2024 in their CKD guideline, they are recommending, we suggest a point of care testing may be used not only for urine albumin creatinine ratio, because the point of care testing machine is also for serum creatinine value also, wherever the access to laboratory is limited or providing a test at the point of care testing facilitates the clinical pathway. So if I have a facility of a nearby lab which can give me the result immediately, if not, it is better. So I mean, in the most of the centers, a point of care testing will be able to detect early, and there are definitely advantages of it, more convenient, minimal sample processing, and a simple analytic process too. You only find what you are looking for. As I told you earlier also, if you are not looking for, if you are not knowing the condition, you will not treat it. You will not ask for the investigation also. So you only find what you are looking for and you don't treat what you don't find. So because you are not asking for the investigation, if it will not be there, you will not be treating it also. And that is what a Professor Peter Rosing long back told. In people with type 2 diabetes, albuminuria increases the risk of heart attack by 3 times. CV death by 4 times and heart failure by 5 times. I am not saying that urine albumin creatinine ratio is only for CKD prevention. Yes, definitely CKD is a major challenge which we have talked, but by urine albumin creatinine ratio, if it is high, it also increases the risk of, because it's a sign of endothelial dysfunction significant, it also increases the risk of CV death, and it also increases the risk of heart failure too. What's the medical treatment options for early CKD? Definitely a tight glycemic control will help. So I mean, if a patient coming with that, using a tight glycemic control, as I told you, the people who are more at the risk of developing CKD, high blood pressure. So the blood pressure control is also very important, and as they are also at the higher risk of developing cardiovascular disease, the lipid profile is to be also controlled with the intensive control, as my previous speaker Joe was talking, that we should have intensively treating the lipid. So it becomes always ABC, A1C, blood pressure and cholesterol. These 3 things are to be done. But yes, definitely there are drugs, as I told you, the SGLT2 inhibitor and newer MRI, which is Findinol, they are to be used for the patient for the further progression to reduce. Angiotensin inhibitor, AC inhibitor or ARB is definitely there. Statins and fenofibrils for the cholesterol, SGLT2, GLP-1 and non-steroidal mineralocorticoid receptor antagonist like Findinol, which is now available to us. These are the drugs which are to be used in patients for progression of CKD to be reported. The holistic approach is that healthy diet, physical activity, stopping using the tobacco product, and the weight management. So these are the other things which we do for all our patients for CKD prevention, like ABC. The same thing we have to continue for the good diet control, increasing physical activity, tobacco products to be reduced, and the fat management is to be done. Urine albumin creatinine ratio versus serum creatinine alone. The NKF and KDIGO guidelines, they talk that serum creatinine alone can quite frequently give a false positive and false negative results. Serum creatinine alone may miss patients who are at stage 1. Patients with normal level of creatinine may still have significant abnormal renal function, and urine albumin is a highly sensitive, urine albumin creatinine ratio is highly sensitive and a specific test. So the guideline is very clearly saying that don't just get the creatine value and don't get that creatine value is normal with that particular lab, that person is not having the kidney problem. But still, person come with the patients come and they show that creatine value is normal and they ask you very specific. Sab, mera kidney normal hai? They specifically ask positively that my kidney is absolutely normal. But when you talk to them about the urine albumin creatine ratio, when you talk to them about that it is increasing, and then we start the treatment. It takes your almost another 5-10 minutes, but definitely then they start doing it more regularly and follow up. To summarize, urine albumin creatine ratio alone gets affected with urine concentration, hence spot urine sample may not be appropriate. Urine albumin testing, ideally rather 24-hour urine collection will be the right method. That what is ideal, but that was not very convenient, and that's the reason a quantitative urine albumin creatine ratio. So before that, the spot microalbumin we used to do, and that was not again. And then the method came that you should do ideally 24-hour urine albumin creatine, and then this quantitative urine albumin creatine ratio came, which is very sensitive marker of albumin. Urine albumin creatine ratio is a guideline. Back method due to be more specific and sensitivity. And point of care testing UACR measurement with CV of less than 15% recommended by KDIO 2024 guideline. The studies prove that cutoff of less than 10, again I am telling you less than 10, is a strong enough marker, but still we use in our clinical practice more than 30 is considered more, because that's, but still a large study they had shown those who were more than 10 found to have increasing mortality too. CKD is definitely a very silent disease. We have to become more proactive. Fully quantitative screening is the first step towards saving kidneys and saving lives. This is the first step which we can do, and a fully automatic quantitative CKD testing is the best way to start. I am sure most of diabetologists across the country now started using point of care testing. Now it's a time that physician adapted. Definitely those physicians working in the hospital environment or those diabetologists and nephrologists, they are working, they have in their hospital the lab, but those private practitioners, diabetologists, endocrinologists, physicians interested in diabetes, because it's not only for diabetes, the hypertension, cardiovascular disease, also you should do the urine albumin creatine ratio. So kidney disease is a silent, detect in time and protect in time. You could help save your kidneys with a very simple urine sugar test, and this is point of care testing machine. I am sure the company people must be here also to show you that what exactly how they do it. And with this, I once again thank you JPEF for giving me this wonderful opportunity, and thank you everyone. Thank you.